This is a presentation on BUMED Instruction 6224.8 Bravo, the Tuberculosis Control Program. So let's break down the instruction real quick before we get started. It's a 6000 series instruction because it has to do with medicine. The secondary number is a 2. So when we're talking about the medical instructions, the secondary number 2 means it's preventative medicine. The tertiary number is also a 2. When we're talking about tertiary numbers in the medical SSIC codes, we're talking about communicable disease, and the 4 designates it as tuberculosis. So 6224, 6 medicine, 2 preventative medicine, the tertiary 2 communicable disease, and the 4 tuberculosis. The purpose of this instruction, BUMED 6224.8 Bravo, is to provide a policy and guidance for controlling tuberculosis among Department of the Navy military personnel and Military Sealift Command civilian mariners. When it comes to Department of the Navy civilians, eligible beneficiaries, inmates in detention and confinement centers, well, their tuberculosis control is going to be guided by current United States Center for Disease Control guidelines and any applicable federal laws. Program summary and strategies to control tuberculosis. Well, we want to promptly detect, treat, and report persons who have developed clinically active tuberculosis. So we're going to differentiate a lot in this instruction between what's called active tuberculosis and a latent tuberculosis infection. Active tuberculosis is highly contagious, so we need to promptly detect and treat it, and then we've got some reporting requirements we're going to go over for anybody with active tuberculosis. We need to protect persons in close contact with patients diagnosed with active tuberculosis or infectious tuberculosis. We need to prevent tuberculosis disease in military personnel and your military Sealift Command and your Department of the Navy employees and certain healthcare beneficiaries through a targeted testing and effective treatment for latent tuberculosis infection. So targeting testing, we're also going to talk about testing versus screening. Testing, as you may already know, that's like doing that tuberculin skin test or we'll go over the blood test as well, where screening is something else. So we're only going to do targeted testing based off of screening, and we'll talk about that a little bit more in this presentation. The Department of the Navy contractors, especially those in a deployment setting, well, we're going to assess to see if their tuberculosis control program is compliant with ours, either through oversight or we just might provide direct care if it's applicable. So contractors, we still have to make sure that they're doing the appropriate things when it comes to tuberculosis control. We're going to go over a couple forms that we need to record tuberculosis program information on. That's going to be the NAVMED 6224/7. This is the initial tuberculosis exposure risk assessment. This would be somebody who comes up positive for a latent tuberculosis infection. This is a form we'll use, and we'll get into some more detail on this. The NAVMED 6224/8. This is the interim tuberculosis exposure risk assessment. This risk assessment is done annually on all our Department of the Navy personnel. And then the NAVMED 6224/9, this is a monthly evaluation. This form is used for a monthly evaluation for any patient who's receiving treatment for a latent tuberculosis infection. You'll notice that the forms, they have the same number as the instruction, the 6224. So that should be easy to remember. If you remember the instruction, we just got to remember the difference between 7, 8, and 9. 7 is your initial exposure, 8 is your annual risk assessment, and 9 is your monthly evaluation if you are being treated for latent tuberculosis infection. You'll find that most of the forms that correlate with an instruction, that they match, the number on it will match the number of that instruction on most of them throughout your bibliography. We got to go over some responsibilities when it comes to implementing this tuberculosis control instruction. So we'll talk about the Navy Medicine Regional Commander's responsibilities. They've got to ensure that subordinate medical treatment facilities maintain an effective tuberculosis control program. Commanders, commanding officers, officers in charge of medical treatment facilities, and fleet and FMF surgeons, well, they've got to control tuberculosis within their population by managing local control efforts in accordance with this directive and current American Thoracic Surgery Society recommendations. Also, they've got to go by the recommendations of the Center for Disease Control and the World Health Organization guidelines as well. And they in addition to that, they also have to follow any federal laws and any state law, state or local ordinances, but as long as they don't conflict with federal laws or Department of the Defense regulations. Okay, so as long as state laws and local ordinances, they don't conflict with federal laws or Department of Defense regulations, they will follow those as well. They are also responsible for assisting the Navy Environmental Preventative Medicine units in the conduct of completing and reporting of tuberculosis contact investigations. So when they do have, and we're going to cover this a little bit more as well, but whenever there is a active tuberculosis case within a command, an investigation will be done, a contact investigation will be done with the cognizant, the responsible Navy Environmental Preventative Medicine unit, and it's a responsibility of commanders, COs, officers in charge to make sure that they are assisting with this. Officers in charge of a Navy Environmental Preventative Medicine unit, well, they've got some responsibilities too, and those will be to provide technical support as needed to all Navy and Marine Corps units in their geographical areas of responsibility. So we have these Navy Environmental Preventative Medicine units throughout the Navy. They are assigned a geographical area of responsibility, and they are there to provide any technical support with any kind of preventative medicine, but especially with tuberculosis. They are responsible for conducting contact investigations of all active tuberculosis cases within the Department of the Navy that fall within their area of responsibility. Going to talk about tuberculosis itself now. Tuberculosis is caused by the Mycobacterium tuberculosis. When people are exposed to tuberculosis, they can acquire what's called active tuberculosis. This is when they have that acute illness, when they got fever, chills, night sweats, unexplained weight loss. They might have hemoptysis, like coughing up blood. That is different than latent tuberculosis. So with active tuberculosis, you are highly, highly contagious, and it's spread airborne. So when these patients are coughing, and when they're coughing in closed facilities like are berthing on a ship or the sleeping arrangements in the field, this disease can spread. It can spread rampantly. Well, people with latent tuberculosis infection, they were exposed to the Mycobacterium tuberculosis, but their immune system is kind of keeping it in check. It's kind of overcome it for the time being, and they are asymptomatic. They do not have symptoms. Not only that, they're not infectious, okay? They can't spread it while they have this latent tuberculosis, while it's in this latent phase. But there is a risk that it may one day become active. So we can test for latent tuberculosis in two methods. We've got the skin test, and we can also test the blood, and we'll get into those in a little bit here. Like I said, when we have a latent tuberculosis infection, it is not infectious. It's only when it becomes active that it is spread, and it is easily spread because it is highly contagious. All right, so our patients with latent tuberculosis infections, we will treat them. There is a treatment regimen we got to get them started on, and this will significantly reduce the chances of them ever having the active disease. So our methods of tuberculosis screening and testing. Oh, nope, not the methods yet. We're going to talk about who we need to test. So tuberculosis screening and testing, all Navy and Marine Corps accessions and any accessions into the Military Sea Lift Command, they must be tested for latent tuberculosis unless they've got documentation of a previous tuberculosis infection that has been treated. Okay, so everybody who's new will be tested. We'll do either the skin test or the blood test on them for all our new accessions into the Marine Corps and the Navy and to Military Sea Lift Command as well. Individuals with a history of tuberculosis or treatment of latent tuberculosis infection must provide that documentation, because that documentation needs to make it into their health record. Otherwise, they're going to be treated just like anybody else. They're going to be tested and treated just like anybody else if they cannot provide that documentation of previous treatment, of complete treatment regimen. Personnel will also be screened for latent tuberculosis infection after receipt of orders to a commissioned vessel during their operational suitability screening. So if you get orders for a ship, you're going to be screened. And we'll talk about some other people who are screened as well. You're going to be screened, and based off that screening, we might do some testing. So we've got to screen anybody that's going to a ship, and the screening form is our NAVMED 6224.8, and that is our exposure risk assessment. And if a positive screen, if you answer yes on some of these questions, well, then we're going to either do the skin test or the blood test. And then if you get orders to a ship and you have a prior history of latent tuberculosis infection, well, you'll be clinically evaluated to make sure that you've completed your treatment or that you're compliant with it. You're currently going through your treatment and you're being very compliant with it. And usually this screening, the suitability screening, it's going to be done within 6 months of arrival on this commissioned vessel. So within 6 months, we're going to do this. So when it comes to our active duty and reserve personnel, they're going to be screened using that NAVMED 6224/8 annually, right? Because every time we do a PHA, we do that once a year. You're supposed to be doing this form as well. You're supposed to be filling out that exposure risk assessment. If the member answers yes on the screening, well, they're deemed to be at an increased risk, and then we're going to do a skin or a blood test on them because they are at that increased risk. Our military Sealift Command personnel, they're to be screened and tested annually during their periodic physical examinations, or they can be screened more often by the direction of their military Sealift Command fleet surgeon. So additional screening for our active duty and subsequent testing can be done more often than annually prescribed if the combatant commander directs it. It can be done as part of a contact or an outbreak investigation. So if a person in a command is diagnosed with active tuberculosis and the Navy Environmental Preventative Medicine Unit comes and does that contact investigation, what they're going to do is they're going to look for all the people who came in contact with this patient, and they're probably going to test those people to make sure that they did not catch tuberculosis. It can be done if it's clinically indicated by an individual practitioner. So you go to see your provider for a clinical visit and they're concerned about tuberculosis, they might test you. Or during your periodic health assessment, you answer yes on your 6224/8, well, then you probably get tested. Or during a post-deployment health assessment or post-deployment health reassessment, if you put some things on there that are concerning for possible tuberculosis infection, you can be tested then as well. We typically don't do testing for separation or retirement anymore unless it's clinically indicated. It can also be, we can also do it more often if the cognizant Navy Environmental Preventative Medicine Unit dictates it. If they say for this area, we're going to do it, every 6 months or whatever the case may be, well, then we would do it. So testing guidance. We're going to start with the tuberculin skin test. All right, the tuberculin skin test is administered by injecting intradermally into the anterior forearm a purified protein derivative. So what this is, this derivative, it's derived from that mycobacterium. It's derived from tuberculosis. And the idea is that if you've had previous exposure to tuberculosis, that just like anything we're exposed to, your immune system is going to have a response, and that response will be to produce antibodies. So the idea is if you've had a previous exposure to tuberculosis, you have those antibodies. So if we give you a protein derivative of that bacteria, if we inject that into your skin, we expect your immune system to attack it. And that's why we measure, right? We measure induration. We that little bit of swelling, that palpable, that bump that you can feel, that is from an immune response. That's what we're trying to elicit, because you wouldn't have that response to this derivative if you hadn't been exposed to tuberculosis in the past, because you wouldn't have those antibodies. So that method of injecting intradermally into the anterior forearm, we call that the Manteau test, okay, or the Manteau method. There's a couple forms we got to record this on. We're going to record it on your immunization record. That's the NAVMED 6230/4, and for children, it's the NAVMED 6230/5. We also need to record it electronically, and we can either put it in ALTA, which stands for your Armed Forces Health Longitudinal Technology Application. We can put it in MERS. MERS stands for Medical Readiness Reporting System, or we can put it in SAMS. SAMS stands for Shipboard Non-Tactical ADP Program Automated Medical System. SAMS is an acronym within an acronym. Like if you take the first S, well, that's all this SNAP, right? The Shipboard Non-Tactical ADP Program, and the AMS, that's the Automated Medical System, Automated Medical System, SAMS. So when we measure, we're measuring the tuberculosis skin test within 48 to 72 hours. So they need to come back to the clinic 2 to 3 days later to get the thing read. If our patient does not return, right, if they wait till after 72 hours, no matter what, we're going to record it as not read, and then apply a tuberculin skin test on the opposite forearm, and then tell them to come back in 48 to 72 hours, and we will read that one. When we go to record the result, we're looking for that induration, that not erythema. So that one, we see some redness, and we're not worried about erythema. We're worried whether or not we have induration, if the skin is raised. So we're going to measure that, and we're going to measure it in millimeters, right? So millimeter of induration, and we're going to put that measurement on the 6230/4 for our adults and the 6230/5 for our children, as well as the electronic medical information system we're utilizing, whether it be ALTA, MERS, or SAMS. If there is no induration at all, it will be recorded as 0, the number 0 millimeters, or we will spell out 0 millimeters. We can do either one of those, but we can't put something on there like negative, okay? It's got to be either the number or spelling out. So in addition to skin testing, we have another method available to us for testing for tuberculosis, and that's the blood assay for Mycobacteria tuberculosis infection, or the BAMT. The brand that we use is the QuantiFERON TB Gold. And the QuantiFERON TB Gold, it is used instead of a TST, of a tuberculin skin test, not in addition. This isn't something we use like to rule in. Like say we get a positive TST, but we're hesitant to start treatment, then we go get a QuantiFERON Gold. No, it's not used that way. It's either or. A positive TST is a positive TST. We start treatment with that. The QuantiFERON TB Gold, it doesn't discriminate between active tuberculosis and latent tuberculosis, and we'll talk about this in a bit here, but whenever we have somebody who's positive with the QuantiFERON TB or the TST, we've got to evaluate them and make sure they don't have active tuberculosis first and foremost. We're going to talk about conversion rates within a command as well. So most of your commands, most of your Navy and Marine Corps commands, they've got a conversion rate of about 1 to 2% of personnel, meaning every year about 1 to 2% of the personnel you test are going to have positive induration on that TST, or they're going to have a positive QuantiFERON Gold test. And that's okay. That's the normal conversion rate for most of our commands. If, however, we have an increased conversion rate, especially if it's 2 times greater than what we expect at that command, well, we need to contact our cognizant Navy Environmental Preventative Medicine Unit and get some guidelines, all right? Get some guidance and to see what needs to be done, to see if an investigation needs to be done for a potential active case of tuberculosis within our command. So if our conversion rate is 2 times greater than the expected baseline, then we got to contact the Navy Environmental Preventative Medicine Unit who's responsible for our area. A couple special situations. We'll run into patients from foreign countries, especially countries with a high tuberculosis rate that have been received the immunization of Bacillus calmette-guerin, or BCG. And for these people, it doesn't matter. We're just going to do everything normally. We're going to test them normally. If that tuberculin skin test is positive. We're going to evaluate them, make sure they don't have active tuberculosis, and then we're going to start their treatment just like anybody else on a latent tuberculosis infection. There's an idea out there that people with BCG get a false positive, but BCG is usually given as an infant. By the time they're being tested with us as an adult, they're not going to see that false positive anymore. It's more than likely they've contracted a latent tuberculosis infection. And not only that, BCG immunization is not highly effective as a vaccine. We can also get false negatives for tuberculin skin tests, meaning people actually have either active tuberculosis or latent tuberculosis, but their skin test comes up negative. And the reason this happens is immunosuppression, right? So immunosuppression when our immune system is diminished. And this can happen for a lot of reasons. Like a patient with an organ transplant, we purposely suppress their immune system so they don't reject that organ. So these people are at high risk for tuberculosis because of the immunosuppression. Not only that, we might see a false negative tuberculin skin test when we go to test them. Patients who actually have advanced tuberculosis, who are acutely sick with active tuberculosis, because their immune system is working so hard, they might give us a false negative. They might not have enough of an immune response to cause that induration when we do a tuberculin skin test on these patients. Patients who've recently received a live virus vaccine. And the reason we get this false negative is, again, our immune system's already working. The immune system's making antibodies for a new exposure. So these patients might give us a false negative. So our guidelines for TST testing, tuberculin skin testing, you don't want to test on the same day that somebody got a live attenuated vaccine. Attenuated means weaken. So like when you get a live virus, it's attenuated, we weaken it. Obviously, we don't want to give you the full strength virus. Otherwise, you're going to get the disease. So we attenuate it, we alter it, we weaken it so our immune system can win. All right. So anybody who gets a live virus, we can give them the tuberculin skin test on the same day, or it's got to be 4 weeks later. Nothing in between. Okay, nothing after that first day up into 4 weeks. Either same day or 4 weeks later. All right, and anybody with a positive tuberculin skin test, these people really should not deploy until their evaluations are completed and all the results have been reported. We got to wait till we get a chest x-ray, and we've got to wait to make sure that these guys aren't active, they don't have, active tuberculosis, and that we've got them on a good treatment regimen and that they'll be able to continue that if they deploy. So these patients, these would be good candidates of doing that quantiferin tuberculosis gold testing on them. These are good candidates for the blood assays, for the blood testing. The blood assay will still give us a good test result. So this would be an example of patients would we do a blood test instead of the tuberculin skin test on. So when we have somebody with a positive test, when we're testing it for latent tuberculosis infection, well, we've got to know how to interpret the TST. So we're going to go ahead and evaluate anybody who has 5 millimeters or more diameter of induration on that tuberculin skin test. And we're going to evaluate them based off of risk factors, and we're going to classify these patients in one of 3 ways. These patients are either going to be considered high risk, medium risk, or low risk. Our high risk patient is somebody who's been exposed to somebody with active tuberculosis. They're either living with somebody or something's happened where we know they've been exposed to somebody with active tuberculosis. This is going to be anybody where we find changes on their x-ray. They got fibrotic changes on their chest x-ray that show that they've probably had a prior tuberculosis infection. This is anybody who's suspected of actually having active tuberculosis. This is going to be a high risk patient. And with these high-risk patients, if they have a reaction of 5 millimeters or greater, that is a positive tuberculin skin test. High-risk patient, 5 millimeters. 5 millimeters or more is positive. In a high-risk patient, anybody around somebody with active TB, anybody with chest x-rays that suggest TB, and anybody suspected of having active tuberculosis based off symptoms. They come in fever, night sweats, unexplained fatigue, unexplained fatigue and weight loss, hemophysis, they're coughing up blood, 5 millimeters, tuberculosis. Our medium risk. Well, our medium risk are going to be any recent immigrants, especially if they come from a region that has a high tuberculosis rate. And it's also going to be people who work in a microbiology lab, because they might be around tuberculosis quite a bit. And anybody with a clinical condition that can put them at an increased risk. Anybody with a condition that suppresses their immune system, like an organ transplant or advanced HIV/AIDS. These are all patients who, at the very least would be a medium risk. And we're going to call a medium risk patient positive when they get to 10 millimeters of induration. Okay, so we give them a little bit more induration than our high risk, right? High risk, we're pulling the trigger on this when they get to 5. Medium risk, 10 or greater, right? Equal to or greater than 10. Our low risk, well, these are patients with no tuberculosis risk factors, right? No risk factors for tuberculosis. Well, they're not positive. We don't call it a positive tuberculin skin test until they get to 15 millimeters. So we classify the patient through a good history of high, medium, or low risk. We consider their test positive if they get 5 millimeters, 10 millimeters, and 15 millimeters. If they're positive, well, we're going to go into what we need to do next. So persons we determine positive either from our blood assay or from our tuberculin skin test, they need to be evaluated by either a medical officer, a nurse practitioner, a physician's assistant, or an independent duty corpsman. They're going to utilize the NAVMED 6224/7. That's our initial TB risk exposure assessment. And they're also going to do a physical exam, an appropriate history, and they're going to get a chest x-ray as well. And that chest x-ray needs to be, examined specifically for signs of tuberculosis. I'm going to scroll across the screen here, an example of our NAVMED 6224/7. Right, our initial tuberculosis exposure risk assessment. It's going to ask some questions, seeing if there's any signs of active tuberculosis. Right, ask if you've had any previous treatment. But that's our NAVMED 6224/7. So when we manage these guys, first and foremost, we got to make sure they don't have active tuberculosis, because one, they could be extremely ill, and they're going to be extremely contagious. So we got to make sure that it's not active, because a treatment regimen is different for our active tuberculosis. So treatment for latent tuberculosis infection, well, we're going to give these guys isoniazid, INH, and the dose is going to be 5 milligrams per kilograms or a max of 300 milligrams. This is a medication that will be taken daily for 9 months to accomplish 270 doses, right? 9 times 30, 270, and we want to try to get that within a 12-month window. An alternate treatment regimen is INH 15 milligrams per kilograms, and that's a 900 milligram max. That's twice per week for 9 months, and a lot of times this treatment regimen is used when we're doing what's called direct observation therapy, and we'll talk about direct observation therapy a little bit more. If known to have contracted TB, so we've got this latent tuberculosis infected patient, a new PPD converter, if we know they got their TB from a patient who has isoniazid or a multi-drug resistant tuberculosis infection, well, we need to talk to our Navy Environmental Preventative Medicine Unit for further guidance on how to go about treating this patient. What are the alternate treatments for somebody with INH resistant TB infection? Typically, we don't do baseline liver function tests unless there's something that suggests that it needs to be done. So if we evaluate the patient and we find that they are at risk for liver disease, or we're concerned that they may have isoniazid-induced hepatotoxicity, then we're going to measure their liver function test based off of that. These guys are going to be followed up monthly, and we already talked about the form we're going to use for the monthly patients. That's our NAVMED 6224/. 9, slant 9. Right? We're going to use a slant 9, and we're going to make sure the whole purpose of them being evaluated is to make sure that they're compliant and to make sure there's no side effects of the isoniazid, because it can be rough on the liver, and make sure that they haven't developed any active tuberculosis. So bring across the screen here our 6224 slant 9, our monthly evaluation for latent tuberculosis. So right there at the top, you see it talks about what kind of medications. Isoniazid or rifampin is sometimes an alternate. We put these guys on B6 in addition to the isoniazid. We see how they're doing, if there's anything in their history that's going to increase their risk of having liver problems, if they're showing any symptoms of active tuberculosis or problems with the medication. NavMed 6224/9. So let's circle back around to direct observation therapy. This is recommended when feasible. This is for your patient who's not very compliant or your patient who's at high risk for active tuberculosis. So these people, since they're at high risk, if they're determined to be at high risk for active tuberculosis, well, we want to make sure that they are compliant. We really want to make sure. So we're going to do that twice a week, 900 milligrams of isoniazid while we watch them take it, because that's the only way we can be 100% sure that our patients are compliant with the treatment regimen. Additional documentation, well, we've got to document our education and counseling we provide for these patients. So you're going to do that on your SF600. And then we're going to document completion of treatment of latent tuberculosis infection. When they finish that 9-month regimen, we want to make sure we've got good documentation, and that documentation is both in their paper and their electronic record. So people are human, and they will miss doses, and that's okay as long as we can get 270 doses of INH within a 12-month period. We don't have to restart you if you miss a week or two or even a month. All right, as long as you can get 270 doses in within a 12-month window, there's no need to restart. However, if treatment is interrupted for more than 2 months, well, first we got to make sure that you didn't get active tuberculosis. So they're going to have to be reevaluated, and we're going to have to rule out active tuberculosis. And then this would be another patient we would consider direct observation therapy on, because it's very, very important that they take this isoniazid. This isoniazid is going to significantly reduce their chances of ever having active tuberculosis. And our patients who we start on isoniazid, well, we've got to ensure that we maintain continuity of care, that they continue to get care even if they transfer. So the medical department, they need to make sure they contact the gaining command that the patient is about to transfer to. We've also got to make sure that the patient has enough medications to continue their treatment while en route to their new command. When people are separating, they are eligible to continue their care at the VA, but we still should do a good job of making sure that they are set up, right? Because we don't want to lose that continuity of care. We want to make sure that they are set up, and we'll resume care even when they separate or when they retire. Some investigations when it comes to tuberculosis, some responsibilities when it comes to tuberculosis contact investigation. So when somebody is discovered to have an active tuberculosis infection within a command, some things need to happen. The commanding officer, the officer in charge, they need to notify the Cognizant Navy Environmental Preventative Medicine Unit and the local health department. Both of them, the Navy Environmental Preventative Medicine Unit, responsible for the area that command is in, and that local health department. The Navy Environmental Preventative Medicine Unit, well, they need to do a TB contact investigation. They need to, see anybody, investigate and see who was at risk for, getting tuberculosis, who was in close contact with this member with active tuberculosis, and get them screened and tested and potentially treated based off of the results of the screening and testing. The Navy Environmental Preventative Medicine Units, they're going to complete their report, and when they do, they need to provide a copy to the command, to the Cognizant Fleet Type Commander Surgeon, and also to the Navy and Marine Corps Public Health Center. MTFs, they will do their own tuberculosis contact investigation, and they will notify the Navy Environmental Preventative Medicine Unit responsible for that area when they do that report. And a copy of their report will be sent to the Navy Marine Corps Public Health Center as well. So when we have active tuberculosis patients within our commands or within our areas, we've got to make sure that we are doing things to protect our non-infected persons. And the way we're going to do that is we're going to put the infected person in a surgical mask, okay? A surgical mask to limit the amount of disease they can spread when they cough. So we're going to put them in a surgical mask while we're trying to get them transferred to a medical treatment facility. And anybody around this patient, well, they need to wear a particulate respirator, right? They need to wear at least an N95 respirator anytime they go in a room with this patient or get too near this patient. There's some additional reporting requirements that need to be done. Tuberculosis, active tuberculosis, is considered a medical event that needs to be reported. We got to do what's called a medical event report, and that report needs to be submitted in 24 hours. Active tuberculosis is a medical event that requires a report within 24 hours, and the method in which we do that is through the Disease Reporting System Internet, the DRSI, and further guidance on that can be found in the Navy Marine Corps Public Health Center Technical Manual 6224.8B. That's the manual that covers your MERS, your medical event reports. And just looking at this and what we know about instructions now, it makes sense, right? 6,000 has to do with medicine, 2, preventative medicine, the tertiary 2, communicable disease. This is a manual on how to do reports on highly contagious communicable disease that require reports on them. Okay, so we made it to the end. Let's review what we've gone over. What form would be used with the PHA to assess a patient's risk of tuberculosis exposure? Which one do we do annually with the PHA? That's the NAVMED 6224/8, the Interim Tuberculosis Risk Assessment. What form would be used to assess a patient with a 5 millimeter induration on their tuberculin skin test? 5 millimeters of induration on the PPD. Will we use the NAVMED 6224/7, the Initial Tuberculosis Exposure Risk Assessment, right? We're going to get a good history, see if this is a high, medium, or low risk patient, and based off of that, then we'll make the decision whether or not we need to treat this patient with medication for latent tuberculosis. What form would be used for a patient being treated for latent tuberculosis infection? So what form are we going to use for that monthly evaluation for somebody who's receiving treatment for a latent tuberculosis infection? Well, that's your NAVMED 6224/9, your monthly evaluation for patients receiving treatment for latent tuberculosis infection. So we've got 7, 8, 9. They're all three of them, 6224, the same number as the instruction. 7, that initial exposure, that first positive PPD. 8, the one we do every year with our PHA. And 9, for when you're positive PPD, when you have that positive PPD and you're coming in for your monthly evaluation. What medication is used for the treatment of latent tuberculosis infection? Isoniazid, INH. That's what we use for latent tuberculosis infection unless we know that the patient got the disease from somebody who has an INH resistant or a multi-drug resistant strand. In that case, we're going to talk to the Navy Environmental Preventative Medicine Unit. What is the typical dose of isoniazid? So what is our dose when we're doing the daily treatment? 5 milligrams per kilogram for a 300 milligram max. How long are patients on isoniazid when being treated for latent tuberculosis infection? How long do we put them on this medication for? 9 months. 9 months are on this medication. Okay, patients often miss doses of INH. They can resume treatment as long as they can achieve blank doses and blank months. Okay, so we can miss some doses, but as long as we get how many in within how many months? Well, that is 270 doses, and we got to get that 270 doses in a 12-month period. What is another method of testing for tuberculosis other than the tuberculin skin test or the PPD test? What is another method? Well, that's our quantiferin TB Gold, our QFT TAC-G, our blood assays for Mycobacteria tuberculosis infection, our BAMT, the blood test. In cases of active tuberculosis in an operational command, who is responsible for contacting the Cognizant Navy Environmental Preventative Medicine Unit? Who needs to contact them when we've got an active case of tuberculosis in our hands? That is the commanding officer or the officer in charge. If a patient has been determined to have active tuberculosis, what type of mask should they be put in until they are admitted to an MTF and put in an isolation room? We put them in a surgical mask. We put them in a surgical mask. So what type of mask does medical personnel need to wear? Medical personnel need to wear an N95 respirator. N95 respirator. Active TB cases need to have a medical event report, a MER, done within how much time? How quickly do we got to get the MER done when it comes to active TB? 24 hours. 24 hours to get that one in. Okay, lastly, let's review our different risks for patients with a positive PPD. So we've got the high risk, the medium risk, and the low risk. Our high risk patients, those are going to be recent close contacts of active tuberculosis disease patients, right? Somebody who is around somebody with active tuberculosis. It's going to be anybody with changes on their x-ray that suggest tuberculosis or prior tuberculosis infection. They got what we call fibrotic changes. This is going to be patients suspected of having active tuberculosis. And we're going to call these guys positive when they get to 5 millimeters of induration. Okay, medium risk. Well, this is going to be anybody who's a recent immigrant, especially when coming from a country with a high tuberculosis rate. This is going to be anybody who works in a microbiology laboratory. And this is going to be anybody with a condition that places them at increased risk, like somebody taking immunosuppressing medications. And we're going to call these guys positive when they get to 10 millimeters of induration on that PPD. And then lastly, our low risk. Well, this is somebody with no risk factors for tuberculosis. So when do we call these guys positive? When they get to 15 millimeters. At 15 millimeters, we'll evaluate them for active TB and then start them on isoniazid more than likely. So that concludes this presentation. This is all from your BUMED instruction 6224.8 Bravo. I really hope that helps you guys out with advancement. Any questions, comments, recommendations, or requests, leave a comment or feel free to email me at robertblakeslee2@gmail.com. You guys have a good one.